All right, welcome to your first year. You're about to start building your psychopharmacology toolkit, and today we are adding a really valuable player, Bupropion. Trust me, this isn't just another antidepressant, it's a very specific tool for very specific clinical problems. So let's get it into your playbook. So think about this. How often are you going to see a patient who's really struggling with depression, but they're also terrified of the side effects they've heard about with other meds? Or maybe their depression just looks like a total lack of energy, zero motivation. In those moments, you're going to need more options in your back pocket. And that option is Bupropion. I mean, look at this list. First off, it hits the two biggest complaints about SSRIs right on the head. It has a way lower risk of sexual dysfunction and weakening. Second, its whole vibe is activating, which makes it perfect for those patients who are just dragging with fatigue and apathy. And on top of all that, it pulls double duty for seasonal affective disorder and, of course, as a huge help for quitting smoking. So yeah, if you want a versatile antidepressant that can tackle a few clinical problems all at once, you're in exactly the right place. Let's dive into the playbook. Okay, first things first, what actually makes bupropion so different from everything else? Well, it all comes down to its unique mechanism. And if you understand this, you'll know exactly when and why to reach for it. So, unlike the SSRIs you're probably already getting familiar with, bupropion is in a class of its own called NDRIs. It works on two completely different neurotransmitters, norepinephrine and dopamine. And this unique pharmacology is where it gets all its benefits, and also its specific risks. And this difference is what really matters in the clinic. SSRIs boost serotonin, which is often calming. Bupropion, on the other hand, boosts norepinephrine and dopamine, which are activating and energizing. But here is the absolute golden nugget for your practice. In the frontal cortex, the part of the brain that's all about motivation and focus, dopamine is actually cleared out by the norepinephrine transporter. So by blocking that transporter, bupropion gives you this fantastic boost in dopamine right where you need it most for those patients with apathy and low energy. It's pretty cool, right? Okay, so with that whole activating mechanism in mind, who is the perfect patient for bupropion? Let's build that clinical profile. You should have bupropion on your radar for any patient with MDD, especially if they're telling you about sleeping too much, feeling exhausted, and just feeling slowed down. It's also a first-line choice for seasonal affective disorder and a fantastic tool for smoking cessation. And here's the big one. It is your go-to for patients who just can't tolerate the sexual side effects of SSRIs or for those who feel kind of blah or apathetic on them. You can even add it to an SSRI to help fight those specific side effects. Now for what is, without a doubt, the most important part of this playbook. Using any medication effectively means using it safely. And with bupropion, there are a few absolute non-negotiable red flags that you have to screen for every single time. I'm serious. Before you even think about writing that prescription, you have to get the answers to these questions. This is a safety check you can never, ever skip. This is the list to memorize. Just burn it into your brain. First, any history of a seizure disorder is an absolute no-go. Bupropion lowers the seizure threshold. Second, a current or past diagnosis of an eating disorder like bulimia or anorexia. We've seen a higher risk of seizures in this group, probably because of electrolyte issues. Third, you've got to avoid it in patients who are abruptly stopping alcohol or sedatives like benzos, because that also spikes the seizure risk. And finally, just like with a lot of other antidepressants, you can't use it within 14 days of an MAOI. Okay, you've picked the right patient, you've checked for all the red flags, so how do you actually start the medication? Let's walk through the standard game plan. For the extended release, or XL formulation, which, let's be real, is what you're going to use most of the time for depression, the titration is super straightforward. You'll start them on 150 milligrams once a day, and always in the morning to help avoid insomnia. Then you wait at least 4 days, see how they're doing with it. If everything's cool, you'll bump it up to the usual target dose of 300 milligrams once a day. For a few patients who might not respond, you can think about going up to the max dose of 450 a day. You'll really only be dealing with two main versions. XL is once a day, which is awesome for making sure people actually take it. SR is dosed twice a day. The key safety difference, and you got to remember this, is with the SR form, you have to make sure no single dose goes over 200 milligrams. That's a huge part of minimizing the seizure risk. Look, no medication is perfect. They all have potential side effects. The key is to know what they are, tell your patient what to expect, and have a clear plan to manage them if they pop up. So because it's an activating drug, the side effect profile makes a ton of sense, right? You're going to hear about insomnia, maybe some agitation or anxiety. That's exactly why we dose it in the morning. Headache, Dry mouth and some stomach stuff like nausea or constipation are also pretty common. But the good news is that for a lot of people, this stuff is temporary. So what's your game plan? First, just wait. Tell them to give it a week or two, because a lot of these initial side effects just fade away on their own. If they're still hanging around and being a problem, you can think about lowering the dose. And if they're just completely intolerable, well, you may have to switch to something else. And now, for an absolutely essential pearl that will save you and your patient a massive headache, you must tell them that bupropion can cause a false positive for amphetamines on a urine drug screen. Knowing this up front saves so much confusion. It's a critical piece of counseling. Okay, so you've done the work, you've made a really thoughtful choice, and you've got a solid plan. Now comes the part where you have to present it clearly and confidently to your attending. Let's practice that. You can just picture it, right? You're on rounds and your attending turns to you and says that. They want to know you've really thought this through. It's not just about naming a drug. It's about making a solid clinical argument. Here's your template. It's 4 easy parts. Start with a one-liner that sums up the patient and their biggest symptoms. Then give your rationale. Connect the drug's mechanism to what the patient is experiencing and point out its advantages. Next, lay out your exact plan, the formulation, the starting dose, the titration schedule, and always finish by confirming you did your safety check. This shows your attending you're not just competent, but you're thoughtful, and most importantly, you're safe. So the big takeaway is this. Bupropion isn't just another option if an SSRI doesn't work. It's a totally different kind of medication that offers unique benefits for the right person. It's a powerful and really effective tool, as long as you respect its rules and use it with care. And that's your prescriber's playbook for bupropion. So tomorrow, when you're on rounds and you see that patient with low energy who just can't tolerate SSRIs, you'll know you've got another great tool ready to go. The only question is, who's that patient going to be?